Assalamu alaikum. First of all, thank you very much for inviting to this prestigious meeting. And let's start without any. First of all, I don't have any conflict of interest except that I use one of the medication that is my interest. Okay, I will go with the introduction, then chronic kidney disease, proteinuria, albuminuria, and significance of proteinuria, and treatment modalities. Introduction: in the individuals with CKD represent almost 5 to 7% of the world population according to World Health Organization. CKD is associated with high risk of hospitalization, especially with the heart disease, and then compared to the general age matched population. With a conservative estimated annual incidence of approximately 10 per 100 per million population, we have more than 25,000 new cases of ESRD patients and each year in Pakistan, and very few have very good access to dialysis and the transplant. We, as with other disease, we also lack significant epidemiological data in our country. We found like one disease, one study in which Dr. Tazeen Jafar et al. Did the survey, the cross-sectional study upon almost 3,000 patients aged 40 plus, and in 12 representative communities in Karachi. And in this, the EGFR was taken less than 60, and proteinuria was taken 3 milligram per millimole. That is almost 25 milligram per gram of proteinuria, and it was found out that the prevalence of CKD stage 3 or above was 12.5%. Proteinuria is a very relatively easy and cheap marker to help guide the treatment targets. And in normal population of 24-hour urine protein is 150 milligram per 24 hour. In the pregnancy, because of the hyperfiltration, the protein amount may go up to 300 milligram per 24 hour. 24-hour collection of urine and protein is standard, and whenever anybody do protein collection for proteinuria, they should also check for the creatinine, so that we can have an idea about the adequacy of the collection. Because 24-hour urine collection is often very cumbersome, and patients sometimes don't collect the last urine, and sometimes they miss the first urine collection. So the collection is often very difficult, sometimes unrealistic. So because of this, if you check the albumin creatinine ratio on the first sample of 24-hour urine, then we can have an idea from the baseline, and then subsequent visits of the patient, we can have spot urine protein to creatinine or albumin to creatinine ratios done. And this should be done on the first morning sample of the urine, not in the daytime, because of the orthostatic proteinuria that may be happening in that patient. Urine dipstick is not a great thing to have some idea of the proteinuria, because whenever the urine protein concentration, albumin concentration is more than 300 milligram per deciliter, then it will be picked up on the urine dipstick. Otherwise, we don't. We do have now assays that we detect albumin in the urine at a much lower concentration, and that's why it is a microalbuminuria. There are some definition that is transient proteinuria, and that happens in patient with having any kind of infection. Even the upper respiratory tract infection may increase the proteinuria, and the patients and the fever is well known to have this thing. So whenever the patient is having and this proteinuria is picked up, we should check the sample again after a few weeks to make sure that patient is not having any transient proteinuria, and rather than spending thousands of rupees for that for normal condition. Orthostatic proteinuria is the major. Orthostatic proteinuria is the proteinuria that occurs because of the activity of the patient, and usually it's normal. It's nothing wrong in it, and so that whenever we see kind of variable results in the proteinuria, we should to try to rule out the orthostatic proteinuria. We can do this by having a first early sample of urine for the proteinuria detection, and in the daytime, if we see it only in the daytime, then we can say that it is patient is having orthostatic proteinuria. Then another condition is overflow proteinuria, and this happens when patient is producing lots of paraproteins, and that those light chains will come in the urine. It's because of the overflow proteinuria. And this thing is very interesting, that these proteins though are not picked up by the usual dipsticks, because usual dipsticks pick the albumin only, not the paraproteins. So if you see that patient is having proteinuria but not being picked up on the dipstick, then this should raise the suspicion of paraproteins. Then the glomerular proteinuria, usually over 500 milligram and typically 1 gram per day is taken seriously, and that we have to manage. Then other thing is the tubulointerstitial proteinuria, and this is usually non-albumin, and they may be produced up to 1 to 2 gram per day. And then post-renal, that is because of obstructive uropathy and bladder tumor, we get these proteinuria, and these are usually not albumin. How proteinuria cause problem? Protein, when it comes in the tubules, most of them get reabsorbed. Okay, and when they get reabsorbed, an excessive amount causes release of vasoactive and inflammatory proteins, and that leads to tubular cells apoptosis and monocyte infiltration, and this is accumulation of interstitium and causes interstitium and extracellular matrix, and that leads to scarring and loss of GFR slowly over some period of time. Proteinuria, that is usually taken as albuminuria because it is coming from the glomeruli. So it is called A1 when there is a normal or mildly increase in the range of less than 30 milligram per gram of creatinine. When it is 30 to 300 milligram per gram of creatinine, it is called moderate proteinuria, albuminuria, or it is called A2, and A3 will be when it is more than 300 milligram per gram. Similarly, when the GFR is more than 90, we can call it CKD1, and CKD2 when it is 60 to 89, but if the patient is not having any protein albumin in the urine, we don't call them CKD. So CKD3 will be when the GFR is eGFR is 45 to 59, and 3B when it is 30 to 44. And severely decreased GFR will be CKD4 when the GFR is 15 to 29, and we call the kidney failure when it is less than 15. Just for our understanding, we call like CKD5D when the patient is on dialysis, and CKD5T when patient has a transplant. Because we added these alphabets because when the patient is having GFR of 10 and they are not on dialysis, so we can have some idea. So the relevance of the detection of early detection of renal function will be that we have an growing problem of this thing, CKD, because we are among the 5th largest population of diabetes, and almost 40% of type 2 diabetics will develop some kind of renal failure. Because of high prevalence and high adverse outcome related to both kidney and cardiovascular, early recognition is very much crucial. Long time ago, we had studies with ACE inhibitors and angiotensin receptor 2 blockers. These studies were published in 2001, and that showed over a period of 4 years, we had 40% absolute risk reduction with the use of losartan and irbesartan in terms of development of renal failure and proteinuria. But thing is that we know that ACE inhibitors and angiotensin receptor 2 blockers and other RAS blockades usually don't fully control the proteinuria. So in last decades, we have developed SLG2 inhibitors and finerenone and sparsentan. Sparsentan is endothelial receptor antagonist with angiotensin 2 type 1 receptor antagonism in it, and finerenone is a non-steroidal selective mineralocorticoid receptor antagonist, and SLG2 inhibitors. These inhibitors are located in the proximal tubules of the kidney and in the podocytes. SGLT1 inhibitors are located in the proximal tubules and also in the gut and other viscera. So inhibiting the type 1 receptors is not very good idea. Patient become very, very sick in the earlier days when they try to use this inhibitor for the treatment. So SGLT2 inhibitors reduces the renal threshold for glucosuria from 180 mg per deciliter to 40 to 120 mg. And because of this inhibition, the usual the patient with diabetic nephron, they have kind of afferent arterial vasodilatation that leads to increase in the filtration pressure and proteinuria. So with the use of SGLT2 inhibitor, we can affect the tubular glomerular feedback by causing increased solute to the distal tubules, and that in turn lead to afferent artery related vasoconstriction, and that's how the proteinuria decreases. And other benefit will be from this thing with the weight loss and decrease in hemoglobin A1c to a mild degree, and decrease blood pressure. SGLT2 inhibitor may decrease the systolic blood pressure to up to like 6 mm mercury and diastolic by 2 mm of mercury. So overall, the benefit from the DAPA CKD trial, that is the circle of 3 diseases: diabetes, cardiovascular disease, and renal. And in all these aspects, SGLT2 inhibitor works. It reduces the major adverse cardiac event, reduces the hospitalization from heart failure, it slows down the decline in eGFR, and often increase the improve the hyponatremia, and of course decrease the proteinuria. And benefit is that this is not associated with the hyperkalemia, as we see with the ACE inhibitor or angiotensin receptor blocker, or with use of receptor blockers from spironolactone or alprazolam. There are these 3 studies of DAPA and crecedence and AMPA on almost 4,000 and 6,000 plus patients, and it all shows that it is associated with significant improvement in the overall cardiac and renal mortality, with the confidence interval of 59 to 82%, and in all these studies, and that decrease the hospitalization rate and slow down the progression of renal disease. The other studies in which it was seen in patients with cardiac disease and non-diabetic patients, again it shows significant decrease in the major adverse cardiac events. And other thing is that with the use of SGLT2 inhibitors, the number needed to treat is like 19%. When in the credence study on glycophysin, when the patient GFR is little low, it helps in the management of the disease. But if the GFR is more than 60 to 70, or if they are not having significantly high proteinuria, we don't see much benefit of this thing. But doesn't mean that we should not start giving it to the patient. We should give it because we may get better cardiovascular benefit from this. From the DAPA CKD trial on the diabetic kidney disease patient and the non-diabetic patient, in all of these patients we see the significant improvement in the GFR and also cardiovascular mortalities. And similarly, in the glyphosine group compared to the placebo, there was almost 34% risk reduction at the age at the 40 2 months of the treatment. Again, in the other study, we had significant also improvement in the composite outcome. Same thing, the other thing is that the change in the GFR in the initial weeks of use of these SGLT2 inhibitors, there is a slight worsening in the GFR, but over a period of months, the things get better. Same is the initial dip again seen in the DAPA trial and the CKT324 and also similarly in the heart failure outcome with the emperor with reduced ejection fraction group, there is also same improvement in the cardiac mortality. Adverse effect of SGLT2 inhibitor, that when we are giving the drug to patients, we should know what are the things we have to look for. Urinary tract infection is quite common in the patients, and it is common, but meta-analysis of SGLT2 inhibitor in trials did not show any increased risk of UTI. The reason could be that if the patient is having uncontrolled diabetes, they are also having glucosuria, and in this the patient also has the glucosuria. That may be one of the reasons that did not show any significant worsening from the general population. But genital mycotic infections are very commonly seen in the female and also uncircumcised male, and that we should be looked for. Other thing is their volume depletion. These inhibitors work as a mild diuretic, and so inadequate fluid intake may cause hypotension, dehydration, and hence combination with other diuretics should be avoided. And our cardiology colleagues do give them furosemide or thiazide diuretics with this drug. In the patient with type 1 diabetes, they develop hypoglycemic ketoacidosis, so it should be avoided in this patient. Other thing is that allergic reaction may happen with this drug, and the thing is this: when the patient is given this drug and the creatinine is not coming down, it's kept going up, and that is a time that you should stop the drug and look for the patient might be having any allergic reaction to it. I had a patient some time ago when I started using these medications. So patient had a creatinine of 1.3 to begin with, and then slowly started creeping up. I went up to like 9, despite the fact that I stopped the drug, and that did the biopsy and found that the patient is having allergic reaction to this drug. So risk medication that when patient develop hypoglycemia with this thing, usually we should not stop the insulin in these patients, and we should manage it by stopping the metformin or other drugs. Sometimes we may have to hold the drug, and we have to control the volume, I think. This phenylalanine, this is not available in Pakistan, which is a potent non-mineralocorticoid receptor and non-steroidal mineralocorticoid receptor antagonist, and there are few trials with this Fidelo and trial, for example, in which 5,700 patients were taken over a period of 22.6 years. There was some decrease in the hazard ratio from 17 to versus 17.8 versus 21%. And in this, usually the number treated to treat was 25%. Phenylalanine is not recommended for a GFR less than 25, and patient is having potassium of 4. Depending upon the stage of the kidney diseases, the dose would be for 20 to 10 milligram per day. In the CKD4 patients, when this was used, that did not that does cardiovascular composite outcome a little bit, but did not show any renal and hyperkalemia problem was quite significant. So it should not be used in the patient with CKD4, GFR less than 25 and potassium more than 5. Finally, the drug is spastin. Spastin is a novel non-immunologic immunosuppressive single molecule dual endothelial angiotensin receptor 2 antagonist. It is one of the non-immunological treatment for IgA nephropathy, and we know that IgA nephropathy almost combined for almost 22% patient with nephrotic syndrome. It was approved by a PROTECT trial in which on the interim databases it has significantly showed improvement at the age of 102 years of the treatment, and it shows significant improvement in the proteinuria. One thing is that this drug should not be used with ACE inhibitor, ARBs or SLG2 inhibitors. So when a patient is not getting better with IgA nephropathy, we should stop these medication and may start them on Spaston alone. Thank you very much.